So I've just started the recording then so that people that can't make the session today can watch this back later, because I think these are going to be really informative education sessions that will hopefully be really useful to your practice. And also for you to learn about what's happening in country SA with our new project, which is the Country Heart Attack Prevention Project. So I will be your chair and your host and your point of contact for these education sessions, which will run if my slides will advance, let me just get this working. There we go, which will run the second Wednesday of each month. However, a little tweak in August just to accommodate the ACRA conference. As I said, they'll be recorded for viewing later. And today we're going to talk about the overview of the CHAP project and the exciting project that's going to be happening in Country SA. And then in July, we'll be unpacking the standardised program content, which is a new document that the Heart Foundation released at the end of last year that I was a co-author on. So without further ado, it's fantastic to see people still joining. If you've got any problems throughout the session or any questions, please feel free to put it in the chat box. I'll be watching that closely and moderating that so I can flag to our presenters. But I will get started because I can see a lot of you are in your lunch break and multitasking, which is fantastic to see. So I will hand you over to Professor Robyn Clark, who will be able to talk to today's topic, which is unpacking the Country Heart Attack Prevention Project.
Okay, thanks everyone. It's a really awful.
You can move the slides with the arrows if you like.
Okay, we're just looking at technology.
Yes, I can move that, yeah. There we go.
Thank you everyone. I'm really proud to overview today the CHAP project. The CHAP project is quite an amazing achievement for a South Australian team that have been working together for 10 years, including myself and Rosie, and I know everyone knows Rosie. So we had done a lot of preliminary work over 10 years, and then we decided to culminate that work after we formed the SA Translation Centre with an NHMRC grant, and we were successful.
Just arrow across. If not, probably. No,
Yeah, it's not working.
there we go.
All right, so that's the name of our project. It's a 4-step model of care and a clinical pathway for translation of cardiac rehab and secondary prevention guidelines into practice. So we're a translation study. So we're not in the research world, we're not like a drug trial or a clinical practice trial. We are a translations trial. So all of the evidence for what we were about to implement has already been sorted. So the problem is getting the evidence into practice and standardizing practice. So that's what we're all about. So next slide. So the background, most of you probably know all this, but as you know, cardiovascular disease kills 1 Australian every 12 minutes. Cardiovascular disease is the biggest killer of men and women around the world and Australia. So in pandemics, there's the breakdown.
Speaker rule. Click on the down arrow.
I can't unmute the person that's on mute.
High definition.
Sorry, someone's talking on the phone at the moment. They're not on. Thank you. And unfortunately, Australians living in rural and remote areas have higher risk factor and 90% chances of being hospitalised for CPD. So risk is much greater in rural and remote Australia. There are 500,000 people living in our community who have had a heart attack, and really, you know, the worst part of the statistics is that 1/4 to half of everyone who has their first heart attack will have a second event. So cardiac rehab and secondary prevention is totally focused on preventing these secondary events, which there is a very high probability. If you were backing a Melbourne Cup horse, you've got a 50% chance of winning, or backing a winner, or 1%. Two very good odds, but not good when you're having a heart attack. And despite years and years and years of research showing that eating a good diet, being active, taking your medicine, seeing your doctor works, we still have a very low percentage of patients showing up to cardiac rehab after their heart attack. And that hasn't changed for 20 years. So at the moment, current research shows about 20 to 50% of eligible people attend. Now, unfortunately, that's not just an Australian statistic. That range of attendance is the same all around the world. So what is it that prevents people from attending? Why don't they come? A great question. So next slide.
Sure.
So maybe one of the reasons is that historically cardiac rehab has been only available face-to-face until just recently when the CHAP system started and we introduced telephone. Unfortunately, also the content and length of cardiac rehab varies across Australia and around the world. So at the moment in South Australia, a rehab program can range from 1 day to about 6 weeks. And that varies across Australia. Some Australian programs are up to 12 weeks. In the US, standard cardiac rehab program is 3 times a week for 12 weeks, so 36 sessions. So the dose of cardiac rehab around the world is quite varied. And until this year, we've never really had KPIs to measure quality of our cardiac rehab programs. There has been a lot of work around the world, particularly in the last decade in the UK and Britain, measuring quality of cardiac rehab services. So we've got lots of background to help us with, and as we were talking about this morning, there are lots of other nursing allied health services like the diabetes educators who've been measuring quality of their services for quite a long time. So we've also got models to look at when it comes to measuring quality. We know that from research, alternate methods of cardiac rehab have been shown to be effective, but few have been implemented. And even with COVID, we don't know if the telehealth versions of cardiac rehab will stay. What I hear is unlikely. So we probably need this project, the CHAP project, to convince the providers, which I don't think will be very hard, that alternate methods are really important. And of course, we argue that the evidence for strategies to modify risk factors have been around for a while, but it's actually just the way they've been delivered that probably is what we need to change so that we can get more people to attend. Yeah, and there was a randomized controlled trial in the UK called the RAMET study in 2012, which did a lot of bad PR for cardiac rehab because the RAMET study showed that attending cardiac rehab made no difference to not attending in the outcomes for the patient. But that actually was the precipitating study to get the UK British Heart Foundation people to look at the quality, and they realised there was a very big, broad range of quality in their delivery. So they're working very hard on improving that at the moment. So they're going great guns. So that's a bit of a history to where we are at the moment. So next slide. Okay. So the aims of the CHAP study. From our preliminary work in South Australia, we identified some of the reasons why people don't attend is that we have limited clinician recommendation. So it's not common for the cardiology round to go up to someone's bed and say, I think you should go to cardiac rehab. I will get the cardiac rehab nurse to come and see you. They might say the part about I'll get the cardiac rehab nurse to come and see you, but they haven't committed the other part of the sentence. So it's well known in clinical practice that if a doctor recommends or tells you to do something, there's a high probability that you will do it. We're also working on reliable electronic and auto referral systems. We also agree that we could do a lot to improve the way people are referred to cardiac rehab. And then finally, CHAP is going to give cardiac rehab, which is going to be very patient-centered. You can design your own menu, you can do telephone, you can do web, you can do it with the GP, you can do all of the above, you can do face-to-face if that's the way you like to do things. So it's very patient-centered. Patient designs their own way to access rehab, and being country patients, that will be entirely dependent on what's available to them in their local area. And then finally, there's this thing in the 2004 Heart Foundation guidelines for cardiac rehab, which talked about phase 3, which is when the patient's discharged to the care of the GP. So we're going to just formalize that relationship. It's really important. Phil Titterman is a great advocate for cardiac rehab being part of primary care and GP practice, and there's quite a few fantastic GPs in South Australia that offer fantastic cardiac rehab support and services. So not necessarily a formal service, but at least maintaining the good job that's been done in phase 2 would be one of the aims of our project. And then finally, there's a disclaimer at the bottom of the slides there to say we acknowledge that we have quite a number of Aboriginal communities in our state, and that it would be fantastic to have cardiac rehab services remotely available to these communities, and we're going to work on that as a follow-on project from this one. But we just want to get it right in the mainstream first, and then we'll get some community folks to come and help design an Aboriginal specific version of the project. So this project will go forever, won't it, Susie?
That's the aim.
Yeah, that's the aim. That's one of our aims, go forever.
Next slide.
So the next is our objectives. So the key objectives are to refine a CHAP model in this first year. So that's what we're busy doing, organising web versions, telephone versions, face-to-face versions, based on the 2019 standardised delivery of practice.
Yeah.
And then we will evaluate how effective that model works in the second and third year, which will be just using pre and post comparisons of the new services, and then compare those to people who didn't receive the CHAP project. And then finally, most importantly, for winning the hearts and minds of our administrators and managers, we will have a really good cost-effective evaluation of this service. So we'll be able to argue that it might even be cheaper. But if not, we talked about non-inferiority trials, it's as good as current services. So that's what we'll be doing behind the scenes in the research side of things.
Next slide.
Next slide. So as I said earlier, this is translation project. We're using pre and post, and we've got a hypothetical economic evaluation. And so our hypothesis is that patients who receive CHAP will have higher rates of attendance and completion, higher rates of risk factor modifications, higher rates of evidence-based pharmacotherapy, and lower rates of morbidity and mortality at 30 days, 12 months. And it will be cost effective. So that's a nice aspirational hypothesis for us. Everyone's agreeing. We're reaching for the stars to be the best in the world. And it's important actually, guys, for you to know that this is world leading. In South Australia, we're doing something that's never been done before, especially for rural and remote patients. So thank you for all your enthusiasm and support, because this is going to be amazing for our patients. Thanks, Susie.
Sorry, multitasking.
So we're going to obviously run this with our great partners at ICCNet. We've got, now because we're rural and remote, we will include everyone, so that's fine. There's no exclusion to anyone who's discharged after a cardiac event. Based on ICC net numbers and country numbers, we should see about 2,000 patients in the year. And we've got our ethics now, was a gigantic achievement achieved by the amazing Susie Cartledge. And with big cohorts like this and with data collected this way in the clinical setting, we've got consent waiver because data collection for quality service delivery doesn't require the detailed consents that like a clinical drug trial might record. So yeah, we're all set to go. Not too many slides. So the model, I think I've mentioned it, but most importantly, all aspects of this version of cardiac rehab will be co-created with consumers. So we're working a lot with consumers. We're going to have a roadshow with some groups when we're allowed to go face to face. As I said, it's based on, we have a saying in the CHAP study that we don't makey-uppy anything. So everything that we're doing is based on guidelines, evidence, and Heart Foundation. I had curriculum at the time, so the standardized practice and the quality indicators. And we also are looking at, when we go and talk to consumers of cardiac rehab, we're specifically going to ask about things that women might find difficult, disabled people, and culturally and linguistically diverse people might want added into a standard cardiac program, because we've identified from the data that these people are low attendees. An example is low socioeconomic. We're going to do a project to measure activity, and so we wouldn't be recommending a $950 iWatch for every cardiac rehab patient as an essential item. We'd have to be aware of what would be affordable in our population and what would be sustainable. So that's our model.
Yep. Next.
And just want to, this is a couple of brag slides really. The final 3 slides is, yeah. The first thing is that my incredible partner and I, Rosie, set out 18 months ago to raise some money, and oh my gosh, the support that we got from SA Health and all our partners still blows me away. So Rosie and I, we won $3.2 million through this grant. We've got just about every leading cardiologist across all of the local health networks. So this is not just a country thing. This is like everyone in the state agreed that this was an important thing, and they've come together to work on this. We've also got great support from the data people at SA Health, like Rosanna, SA Translation, Wendy, etc. And what at the time we were writing, there was the Transforming Health group, but we do have obviously good support from SA from what you can see there. So the next slide shows that Rosie and I, together as a dynamic team, raised $1.8 million in support from our partners, and the partners are listed there. Cardiac Society, 2 pharmaceutical companies, Novartis and AstraZeneca, Flinders Foundation, the Royal College of GPs, ACRA, ESSA, Primary Health Networks, great partners, they're going to be quite significant. SA Health were amazing, and Country Health SA, which is now defunct, but they were also amazing. And the Heart Foundation, we won $150,000 from the Heart Foundation. So not only should you be excited that this project is happening in Country SA, but be excited by the amount of support that we've got to make some pretty fancy things happen.
Next slide.
And so that is my last slide, Susie.
Yes.
And our team's been working hard on this word called impact. So I tried to articulate what will be the impact of the CHAP study. So we're hoping that the CHAP study, with all its versions of delivering cardiac rehab, being patient-centered and cost-effective, will be highly effective and generalizable. More people will come, more people will reduce their risk factors. And that we will be showing the whole of Australia how to do this, and they'll all be going crazy trying to copy CHAP. So stay tuned, we'll be famous. And also, why shouldn't this be a model that could be used for cancer patients in country, for diabetes patients in country, for maternal health in country? So we're saying that the model itself will be easily adaptable. I spoke about having an Aboriginal version later on, and the amount of support that we've got from our partners and investigating. The final dot point is most important, that the people on this team will make sure this happens, and they'll make sure that it's supported, and we're going to make sure that it becomes a sustainable, ongoing service that isn't just like a research project that happens and then goes away. This is the real deal, and we will be investing $3.2 million into a first-class cardiac rehab service for country South Australia. Is there anything you want to add there, Rosie? Thank you. Covered it all. Thank you. How's that, Susie?
Great, yeah. So I might open it up for questions. I'm just going to put all of your beautiful faces, for those that have cameras on, don't feel you need to have your camera on, up on our screen so we can see. Is there any questions for Robyn? And if you do have a question, you can unmute yourself and just introduce yourself. That would be great. Or if you'd like to do it by the chat box, I will read it out. So is there any questions for Robyn? Maybe you explained it perfectly, Robyn.
Well, how are we going to make this happen? You know, what's in it for you? So
I've got a slide on that.
Yeah, Susie's going to follow my talk.
Yeah.
With which is probably what you're thinking. Well, new clinical pathways, new this, new that. But how does this affect me? So I will hand over to Susie, and maybe she'll stimulate a bit more
discussion. I'll just get this off the screen.
Would you like the camera?
Yes, sure. Thank you. Sorry, I'm multitasking with the technology and the speaking. My favourite jobs. Okay, so before we go on, I just wanted to introduce the CHAP team as well. So you would have seen on Robyn's slides there that we've got a management team which consists of our key clinical partner, which is ICCNet and Rosie Tiramacco. We've got Robyn Clark, myself as a senior research fellow, swayed and moved all the way across from Victoria to be part of this project. So that's how good it is. Yes, I left the jabs behind, and I have done 2 weeks of quarantine, so I'm very clean, I can assure you. And I'd also like to introduce, and I'll get her to come up here so that you can see her face. Yeah, you have to be on the camera. Our project manager, which is Kay Gobin, and she will be a key. So just wave to the people. No, this here.
Oh,
yeah. So this is Kay, our project manager. So when you see us out and about, we're the 4 key points of contact for CHAP, and I'm the key point of contact for the education program that will be running every month, which is fantastic. So, big question, what is in it for you? That's the main question. And we've been really thinking a lot about this. Obviously, we want to improve cardiac rehab. We want to improve access. We want to get more people through. We're not trying to take over face-to-face patients. There's so many patients, 70%, that don't come to rehab. So we want to give them an entryway in. So that's one of the big things. So hopefully through CHAP, we will be able to increase your capacity as well through having these alternative modes of delivery. Obviously too, this education program will run once a month. So we do have a few topics mapped out for the rest of the year, but we're very open to having topics that you would be interested in that would help to complement your practice, to help you roll out the CHAP program. Through our networks, we can certainly try and secure some external speakers. If you want to hear from someone overseas that's doing something similar, we can certainly try and organise that for you. We're very happy to do that, and that's one of my passion projects, so I'm very happy to do that for you. So in terms, just getting back to the infrastructure, with CHAP, we will be able to assist you with data collection. I know a lot of you, or all of you, are doing that already. So we'll be able to enhance that even further. We're planning to give you reports for services to see how you're going, how are your patients going, what are your outcomes looking like, so that you can really see the difference that you're making in your patient cohort. The other thing we're doing, which is just in progress at the moment, and some of you are clinically reviewing it for us at the moment, which I say a big thank you for, is we're going to have a CHAP clinician manual. So we're not trying to tell you how to do your job. You all know how to do that. But basically what we're trying to do is to help operationalise the 2 new key documents that are available for cardiac rehab clinicians in Australia. So one is the Heart Foundation Pathway to Cardiac Recovery, a standardised program content. It's got the longest name in history, which has just been released at the end of last year. And the second thing that we're going to help operationalise in that manual is the new National Cardiac Rehab Quality Indicators as well. So we've done all the hard work. The manual's very comprehensive, probably too comprehensive, but it's all there. And say you have someone that's coming into your program for 3 months, an allied health professional that's going to deliver an element of cardiac rehab for you, you can give them the manual. Hey, just so you know, this is the section that we deliver. This is a great guideline and a great resource for you to be able to deliver, because we do want to aim to move towards a level of standardization using that standard program content from the Heart Foundation, so that everyone is getting a similar product and a quality product at that. As I said, we're going to have alternative delivery methods to help you increase your capacity, but not your workload. So we're planning all of that at the moment, and we will be providing some reports and data so that you can see how you're going as well. So the other thing that we wanted to point out too is that we will be, as Robyn alluded to, we will be holding a roadshow. We will be coming around. We will be contacting people. Some of you have already been contacted to assist with the CHAP clinician manual. So you will have a chance to co-design this with us, to come on the journey with us, and to really you know, make cardiac rehab in South Australia the best cardiac rehab in Australia, and everyone wants to copy us and say, oh, those guys have got it, they're onto it. So we want you to be in the world. Sorry, I'm not thinking big enough. We're going to be the best in the world. Best in the world. So we want to take you on that journey with us as well. So I also just wanted to do anyway, I'll pause there for a second. Is there any questions? That's a very important part to pause on. And feel free to type them to me in the chat, or to unmute yourself, and we can talk to you in the room. Any questions? I hope you can hear us and that you've been able to follow along okay at your end. Yep, good. There's a few nods. I'm looking at my chat box. It's also empty.
Very good.
Maybe everyone's just so excited they just don't have any questions. No, don't.
Hey, my name's Michelle Schilling. I'm a dietitian by background, so ACL dietitian linking in for allied health. I just wanted to query around the consumer engagement and just checking, well, actually more consumer feedback. Are there methodology that you've put into CHAP around that as well?
Yes, so we will be sort of getting a consumer panel together. We will be doing some co-design workshops with consumers to make sure that CHAP meets their needs and is what's going to help them to get to cardiac rehab and to complete their program. So that's a large part of our project. Definitely. Great question, Michelle. Thank you.
And I was just thinking about survey feedback. Sorry, we've just have that with the Health Direct system at the moment. Is that something that you're looking at the end of the course as well, just around how they found that level of engagement?
Yes, so we've built into the data collection patient-reported experience measures, so that, and I can't select some of those, but we will build in prems into our data collection as well at the end of the cardiac rehab program. Yep, great question.
Great, thanks.
Great. Is there someone else I heard?
Yes, it's here. Can you hear me, Kay?
Yes. Hello.
It's Kerry Johns. I just want to know, in regard to the standardisation, does it mean that we will also have standardised assessment forms and 6-month reviews and 12-month reviews? Is that going to be happening as well?
Yes, yeah. So that's all part of the process and what we can give to you as well. So I know you're all entering data at the moment, and that process probably won't change that much, but we will be providing you with that sort of roadmap for a comprehensive standardized assessment, and some options on how to get that done, especially if you don't have capacity. So perhaps tapping into your GP, maybe they can do a portion of it or do the whole thing. So yeah, we will be providing that as well. And that will be aligned with the standardized program content from the Heart Foundation and also the National Cardiac Rehab Quality Indicators. And we're going to be unpacking each of those documents in the next 2 sessions of this program. Thanks, Kerry. Great question. Anyone else? No? And you can also feel free to email us at any time as well, and we can try and answer questions that way too. But happy to keep these if I can talk, discussions going each month when we meet like this. Tony has just emailed me a question saying, when will the roadshow be? We will let you know. We're just trying to work in with sort of coming out of COVID restrictions. So we'll be in touch and we'll come and visit you directly, Tony.
Hopefully this half, second half.
Yeah, hopefully later in 2020.
Yeah, we hope to get around to see everyone
Yeah.
face to face, and we'll do patient consultations, but we'll also give any in-service that anyone wants us to do.
Yeah.
While we're there.
We provide a full service. Excellent. Anyone else? Don't be shy. No silly questions either. I used to teach year 10s first aid. You can't beat the questions they ask. Okay, if not, feel free to keep them coming, but I'll just, in the interest of time and knowing that this is probably your lunch break, I just wanted to, while I've got a captive audience, I would be a terrible scientific chair of the ACRA conference if I didn't plug my own conference. So just hope that you're all aware that ACRA is going to continue this year. The conference, it's on the same dates as we had originally planned. We have done, to use the in lingo, we've done the pivot from face-to-face to a virtual conference. So we've gone virtual, not viral. And because we've gone virtual, it's really fantastic. Everyone will be able to access the conference really easily, and it's priced really well as well. So for the whole 3 days for ACRA members, it's $300, and that's exactly the same program that we were going to deliver face-to-face. So you're getting the same content for a far cheaper cost as no travel as well, obviously. And the other great thing about a virtual conference is that everything will be recorded and will be available to delegates for 90 days after the conference on the conference platform. So if you are on shift or you can't make it on the 10th, 11th, 12th of August, or you have to, have an afternoon away, that's fine. You can catch up on anything that you've missed because it will be recorded and stored for viewing up to 90 days after the conference. So I just wanted to give you a plug. If you're interested in more information, head to the ACRA website. The full preliminary program is up for perusal, including the free paper abstracts and the prizes. So have a look to see who's competing for the research prize, the clinical prize, exercise prize this year. And we've got some great speakers. We've got international speaker Erin Donnelly, or now known as Erin Nikos. We've got Stephen Nichols, who's the head of the New Heart Hospital in Melbourne, and obviously former SA person. So really fantastic program that you don't want to miss.
Do you want to mention who won the prize last year?
Yes, and obviously someone who's online now won the, I think it was the Clinical Excellence Showcase, which is Claudine Clark, so one of our own. So well done, Claude. She's probably in the other room here at ICC Net cursing me.
Great.
Yeah, so yeah, come along. It'll be a fantastic conference, and we've had to work really, really hard to pivot it to online. So please come and support us as well and do all our hard work. So that is really the program for today. I guess my other 2 questions in terms of the person that's chairing and organising these sessions is, we have had a pretty amazing turnout for this first session, and hopefully that continues. I have had emails from people that Wednesdays doesn't work for, but on the whole, if this time is terrible for you, please let me know and we can think about a tweak. But we have planned them for the second Wednesday of every month. They will be recorded. We will send the link out to you, and we will eventually have a CHAP website where there'll be a repository of the slides and the recording and any other resources. So if we talk about a paper, we'll make sure that's all available for you as well, because this is a key part of the CHAP project, is to deliver this high quality education. So the other question I had too was, Looks like most people have had a great sort of, Zoom has worked really well today. So we'll just, our plan was to use the DTN, but that plan did not go to plan. But yeah, if everyone's happy with Zoom, we can continue in this format. Or the other thing we can do is we can do MS Teams. So if you've got any feedback about any of those things, Tony's nodding at me. Then getting a thumbs up, good, thanks Tony. Then please let us know, because we really want to try and reach as many people as possible, but please be reassured that we will record them and that they will be available for viewing later on. So oh yeah, and please feel free to email me any suggestions for topics or speakers that you would like to come along to these sessions, because we're very open for that as well. Any final questions before we end today's first session? And on time, I'm very pleased to say. No? Smiles, that's good. Zoom works well, great. Excellent. Excellent, and then you can dial in from anywhere. I'm getting a thumbs up, thanks Kerry. I love that everyone knows how to use Zoom and all the cool features now. I'm loving all the backgrounds. Rosemary's got a great background there in Gawler. Fantastic, all right. I'll let you go and continue on with your day. It was so fantastic to see you all here for that first session, and we look forward to seeing you next month. Any feedback, please feel free to email me. Have a great day, everyone.
Bye.
Thank you.
Thank you.
Thanks, Susie.